Welcome to the Deep Dive, the show built entirely around your sources. We distill complex research and clinical literature into, well, actionable knowledge.
And today we have a really critical topic in modern oncology.
We certainly do. We are taking a deep dive into the molecular identity and the rapidly evolving treatment strategies for triple-negative breast cancer, TNBC.
It's a challenging topic, absolutely. TNBC makes up maybe 15 to 20% of all breast cancer cases, but its impact it's just disproportionately large.
As is defined by what's not there, right?
Exactly. By the strict absence, the complete lack of three key receptors, that's the estrogen receptor, or ER, the progesterone receptor, PR, and then HER2.
And that total absence is the core of the clinical challenge, isn't it? It means all those really effective targeted therapies we have, hormone blockers, HER2 drugs.
They're completely useless here.
Useless.
Lacking those targets forces us to rely primarily on systemic chemotherapy, which is, inherently less precise.
And the data on that is pretty stark.
It really is. TNBC is just so aggressive. Recurrence can happen much, much faster. We're talking an average of maybe 19 to 40 months.
Compared to, 5 years or more for other types?
Right. Compared to 35 to 67 months for non-TNBC.
Right.
And if it metastasizes, the median survival is tragically low, only about 13.3 months.
Wow.
That statistic alone really underscores why we have to understand the deepest molecular secrets of this disease.
It absolutely does. So over the next few minutes, we're going to dissect that aggression. We'll unpack the molecular complexity, look at cutting-edge diagnostics, and detail the really promising landscape of therapies, from conventional to immune-based. Okay, let's get into those molecular features, because if you can't target what's there, you have to exploit the liabilities created by what's missing or what's broken.
That is the core idea of modern TNBC treatment. You have to find the tumor's Achilles heel. And genetically, TNBC it's characterized by massive instability.
Hallmarks of aggression, I assume.
Yes. High mitotic numbers, frequent TP53 mutations, both are signs of just rapid, out-of-control division. And something like 70% of TNBCs fall into what we call the basal-like subtype.
And the most famous connection, the one that's really therapeutically relevant, is the link to BRCA1.
It's the strongest link, without a doubt. Over 80% of breast cancers that are linked to a germline BRCA1 mutation, they're TNBCs.
And the other way around.
The other way around, about 1 in 10 TNBC patients carries that mutation. And this directly points to defects in DNA repair, specifically a pathway called homologous recombination repair, or HRR.
And even if the BRCA gene itself isn't mutated, that pathway can still be broken. This is BRCA-ness, right?
It's BRCA-ness. The whole system is dysfunctional.
So that defect, that inability to properly repair its own DNA, that sounds like a huge liability for the tumor.
It's a massive weakness we can exploit. And this is where the concept of synthetic lethality comes in. It's a beautiful idea, really.
Explain that for us.
Okay, so the tumor is already limping along with one broken mechanism, HRR. If we then use a drug to break a second non-critical repair mechanism, the tumor just loses all its backup systems. It collapses and dies.
But our healthy cells, which have that first mechanism intact,
our healthy cells, with their intact HRR pathways, they just shrug it off and survive. It's an incredibly specific way to target the cancer.
that is a game changer. So moving from a single gene, let's talk about the bigger picture, the heterogeneity. The research shows TNBC isn't one disease, but 6.
That's right. Based on that seminal work by Lehman and his colleagues, they classified it by gene expression. You have basal-like 1 and 2, mesenchymal stem-like, mesenchymal immunomodulatory, and luminal androgen receptor.
And these aren't just academic labels. They actually dictate how you would treat a patient.
Oh, absolutely. They point to completely different strategies.
So can you walk us through the 3 most clinically distinct subtypes? How does this change the approach for, say, a young professional starting in this field?
Of course. Let's start with the LAR subtype, luminal androgen receptor. It's the one outlier because it expresses the androgen receptor, AR.
So you can target a hormone receptor, just not ER or PR.
Exactly. And it also has high rates of PIK3CA mutations. So the clinical approach here, it shifts completely. You use AR inhibitors, and you often combine them with PI3K inhibitors to hit that second pathway.
Okay, what about the others?
Then you have the IM subtype, immunomodulatory. And this one is fascinating because it's inherently, immunogenic. It's packed with immune cell pathways. T cells, B cells, you name it.
So the immune system already sees the tumor.
It's screaming at the immune system. So for these patients, the logical step is to use immune checkpoint inhibitors to basically unleash those T cells that are already there.
And then there's the more stem-like subtype.
The MSL subtype, mesenchymal stem-like, high levels of stemness genes, which means it's good at migrating and resisting treatment. So here you target pathways that support that plasticity, like with PI3K inhibitors or CRC antagonists like dasatinib.
And beyond the DNA code itself, the sources really stress epigenetics, changes in how genes are regulated.
They're crucial. With DNA methylation and TNBC, you see this strange pattern of global hypomethylation. The whole genome is less methylated, but with specific hypermethylation on certain CpG islands.
And that hypermethylation correlates with something called H3K27E3. What does that actually do?
Think of it like an epigenetic off switch, a silencing marker. It's the cell's way of permanently gluing a gene shut.
So it's silencing tumor suppressor genes.
Precisely. And that's where some of the new drugs come in. We can target proteins, BET proteins, for example, that are involved in reading these histone modifications. Inhibitors like OTX-015 can block the cancer cell's ability to read those instructions.
So you're not just attacking the mutation, you're attacking the cell's whole regulatory system.
Exactly. It's a huge step forward.
Yeah.
No, that brings us to how clinicians actually detect and monitor this disease, because that rapid growth rate creates some unique and sometimes counterintuitive features on imaging.
Let's start with the standard tool, mammography.
Yeah.
Why is TNBC so hard to spot there?
It's often mammographically hidden, in up to 18% of cases, actually. It tends to lack the classic signs we look for, like calcifications or spiculated borders.
Which suggests it just grows too fast for those to develop.
That's the theory. It seems to skip that slow in situ stage, which makes other tools essential.
Like ultrasound. How does it do?
Ultrasound has good sensitivity. And a key feature of TNBC is that it often shows up as a distinct mass with, get this, well-circumscribed borders and posterior acoustic amplification.
Wait, but aren't those features that usually suggest a benign mass?
They are, and that's the counterintuitive part. In other breast cancers, yes, that's reassuring. But in TNBC, it often indicates rapid internal tumor necrosis. The tumor is growing so fast, its blood supply can't keep up.
And MRI is the gold standard for sensitivity.
It has the highest sensitivity, yeah, reaching 100% in some studies. And again, you see signs of that rapid growth. A key feature is rim enhancement in about 3/4 of cases, and increased T2 signal intensity inside the tumor.
Which again points to that internal necrosis.
Highly correlated with it. It's a direct sign of aggression.
So moving beyond these static pictures, the future is clearly in real-time monitoring. In liquid biopsy.
Liquid biopsy is a dynamic snapshot. It's a game changer for monitoring therapy. We're using blood samples to look for circulating tumor DNA or ctDNA, microRNAs, and exosomes.
Why is ctDNA so powerful for real-time tracking?
Because it's shed directly from the tumor cells, and the amount reflects the tumor size. But the crucial part is its half-life. It's remarkably short, sometimes as little as 15 minutes.
So if a treatment is working?
The drop in ctDNA levels is almost instantaneous. You can see if a therapy is working far, far quicker than waiting for a tumor to shrink on an MRI scan.
And we need really sensitive tech to catch these tiny amounts.
Yes, and that's where digital PCR or dPCR comes in. It's superior to traditional qPCR because it gives you an absolute count of molecules without needing a standard curve. It's sensitive enough to detect minimal residual disease.
Integrating that sensitivity with imaging. That brings us to immunopity.
Immuno-P is functional imaging. We use radiolabeled monoclonal antibodies, think of them as tiny GPS trackers, that hunt down specific markers on the TNBC cells, like tissue factors.
So it's not just for detection.
It's for treatment selection. You can verify that a patient's tumor actually has the target before you give them a targeted drug. It's truly personalized medicine.
Okay, let's shift from finding the disease to fighting it. And chemotherapy. That's still the cornerstone, right?
It is. Without those hormonal or HER2 targets, cytotoxic agents are our primary tool. Taxanes like paclitaxel are essential. They block cell division. And those basal-like subtypes we talked about, they show a 4-fold better response to taxanes.
And given those DNA repair defects we mentioned, platinum agents seem like a perfect fit.
They're critical. Cisplatin, carboplatin, they work by causing DNA damage. And because TNBC cells with that BRC anus can't repair that kind of damage efficiently, they are highly sensitive.
And this brings us back to that idea of synthetic lethality. How is that being applied in the clinic?
This is where PRP inhibitors, or PARP, come into play. They are the drugs designed specifically to exploit that HRR liability.
So how do they work?
Okay, so PRP proteins normally repair simple single-strand DNA breaks. If you use a drug like olaparib to inhibit PRP, those single-strand breaks escalate into much more serious double-strand breaks.
And the TNBC cell, with its broken HRR pathway.
It has no way to fix them. The damage accumulates and it leads to catastrophic failure, cell death.
That's incredibly elegant. Is this for all TNBC patients or just those with the BRCA mutation?
Right now, it shows the strongest benefit in patients with a confirmed germline BRCA1 or 2 mutation, but research is definitely expanding to see if it can also help patients with that broader BRCA-ness phenotype.
So beyond DNA repair, what about other dysregulated pathways? PI3K.
The PI3K ATM-TM-TOR pathway is highly dysregulated, often due to PUPin loss. We have inhibitors like everolimus, but the big takeaway here is that monotherapy is probably going to fail. These have to be used in smart combinations.
And what about EGFR? It's expressed in 80% of TNBCs.
Right, but targeting it alone with something like cetuximab, that largely failed. It's the same lesson, really. In such a complex disease, single-agent targeting just isn't enough.
So you combine it.
Exactly. Pairing it with platinum agents, for example, is proving much more effective.
And lastly, CDK46 inhibitors.
Inhibitors like palbociclib seem particularly effective in that LAR subtype. And what's interesting is, beyond just slowing tumor growth, they also seem to slow metastasis by destabilizing a protein called SNAL1. And that brings us to immunotherapy. This is probably the biggest paradigm shift in TNBC management, and it's precisely because of the disease's inherent instability.
We established that TNBC has a high tumor mutational burden. So why does that make it so vulnerable to immunotherapy?
Well, all those mutations from the unstable genome, they generate numerous neoantigens. These are mutated proteins that the immune system sees as foreign.
So it makes the tumor more visible to the immune system, more hot.
Exactly. The problem isn't that the immune system can't see the tumor. The problem is that the tumor has built a very effective defensive perimeter.
The tumor microenvironment, or TME, where it actively suppresses the immune response.
Right. The TME in TNBC attracts lots of tumor-infiltrating lymphocytes, or TILs, but then it immediately neutralizes them. The cancer cells recruit these pro-tumor M2 macrophages and N2 neutrophils that basically act as the tumor security detail.
And the most direct weapon in that arsenal is the immune checkpoint system.
Correct. TNBC cells plaster themselves with checkpoints like PD-L1. When that PD-L1 on the tumor binds to PD-1 on a T cell, it hits the brakes. It inactivates the T cell, and the tumor escapes.
So the goal of immune checkpoint blockades, ICIs, is to release that brake. But the sources say that using them alone, the response rates are modest.
They are, often under 20%. The real power we're finding is in the synergy with chemotherapy.
Wait, so chemotherapy, which we think of as suppressing the immune system, actually helps immunotherapy?
It does. It's a powerful immune modulator. It's a multi-pronged attack. First, some chemo drugs, like anthracyclines, cause what's called immunogenic cell death. This basically sounds an alarm that triggers a robust T cell response.
And there's a second part.
Yes. Other drugs, like taxanes, actively recruit more TILs to the tumor while simultaneously getting rid of those suppressive pro-tumor cells. So the chemo essentially turns a cold, suppressed TME into a hot, activated one. It primes the battlefield for the ICIs to work much more effectively.
Okay, this is where it gets really interesting, how technology is maximizing these combination strategies. Let's talk about nanotechnology.
Nanocarriers, things like liposomes or polymeric nanoparticles, are a total game changer for drug delivery. They protect the drug, they increase its half-life in the body, and they minimize those awful systemic side effects.
And they use the tumor's own weaknesses against it to concentrate the drug right where you want it.
They do, through two main methods. The first is passive targeting. It uses what's called the EPR effect. Enhanced permeability and retention. Meaning a tumor's blood vessels are leaky, like a sieve, and its lymphatic drainage system is blocked. So these nanoparticles can slip into the tumor easily through the leaky vessels, but they can't get washed out.
So the drug just accumulates inside the tumor.
Exactly. It can concentrate the drug up to 100 times higher than with traditional methods.
100 times?
Yeah.
Wow, what about active targeting?
Active targeting is even more precise. We use ligands on the nanoparticles that bind to receptors overexpressed on the TNBC cells. For example, we can coat nanoparticles with hyaluronic acid, or HA.
And that targets.
It specifically targets the CD44 receptor, which is often highly overexpressed in TNBC. The HA coating is like a key that unlocks the cell, ensuring the nanoparticle gets inside.
And finally, let's touch on antibody-drug conjugates, ADCs, the chemotherapy-guided missiles.
They are incredibly effective. You get the precision of a monoclonal antibody combined with a super potent cytotoxic agent.
Give us an example.
A key one is sacituzumab govitecan. It targets the TROP2 receptor, which is on a lot of TNBC cells, and it carries a powerful chemotherapy metabolite called SN38.
And there's another major one.
Yes, letertuzumab vedotin, or LV. This one targets the LIV1 zinc transporter, which is upregulated in most breast cancers, and it carries a potent drug called MAE. And what's really exciting is that early trials are combining LV with immunotherapy.
Suggesting the ADC might also help prime that immune response we talked about.
Exactly. The cell death caused by the ADC might also contribute to that immune modulation, creating a really powerful synergy.
So what's the big takeaway from all this? For you, as someone getting up to speed on this field, the crucial synthesis is that TNBC treatment has moved past that initial paralysis of not having any targets.
Right, we've gone from just reacting to the triple negative label to actively exploiting the disease's inherent vulnerabilities, its instability and aggression.
Exactly. The whole field is shifting toward these highly personalized combinatorial approaches. It's about understanding the immense molecular heterogeneity, knowing ALAR from an IM subtype, and then hitting those vulnerabilities.
So using PRP inhibitors for HRR defects, using chemo and ICIs for the immunogenic tumors, and optimizing the delivery of all of it with nanotechnology and ADCs. That's the path forward.
That pulls together a huge amount of data and really sets the stage for the next generation of care. So to reinforce all this and give you something to think about, here's a final thought. We've established that TNBC, despite its aggression, has high genomic instability and a high tumor mutational burden. So why is this high mutation rate considered a double-edged sword, and how is it being exploited therapeutically in TNBC patients? Think about the concepts of synthetic lethality and neoantigen generation for the immune system.